have a problem in American healthcare. A lot of people don't realize it, but healthcare in American hospitals is not safe. Partnership for Patients is a unique public-private partnership that's never been done before.
Since this initiative was launched in April 2011 by Secretary Sebelius, we've already racked up some impressive results. More than 6,500 organizations have enrolled into the Partnership for Patients, including more than 3,000 hospitals. It establishes two bold national aims: a 40% reduction in hospital-acquired conditions and a 20% reduction in 30-day readmissions.
We're working very closely with those state associations to reach all of the hospitals we possibly can across the nation so that we can help deliver the best information about what effectively works to drive down hospital-acquired conditions and to improve our readmission rates.
The South Carolina Hospital Association, along with over 30 other public and private sector healthcare partners in South Carolina, have been working for the last 5 years through the Every Patient Counts partnership to improve the quality and safety of care for every patient in our state. More recently, we've aligned that work under the National Partnership for Patients, specifically focused on reducing preventable harm to patients across our state and reducing readmissions and improving care coordination and transition for patients statewide.
There has to be a culture of safety. So we developed this toolkit that has everything in it, lots of information about what the problems are in terms of patient safety and what you can do about them, and then what the board can expect from the institution that they are fiduciary for, and how they can drive change to a culture of safety.
We work with a partnership of hospitals and long-term care centers, and we're matching up providers in the acute and the long-term care realms, and we're working very specifically with patients and identified family care partners, and we're equipping them with the training to use and create their own health record, their own electronic health management record that then they take with them to different sites to build their confidence, their health confidence or their self-confidence in their ability to manage their own chronic conditions. And that's been one of the pieces that's been missing.
With reducing central line-associated bloodstream infections, we have seen a 69% reduction. We're really changing the culture in the operating rooms across the state, and we've seen some early reductions, about 25% in surgical site infections. Looking at the cost impact, we have done some measurements as far as it relates to central line infections, and we've seen probably about just in that one initiative, about a $10 million reduction in cost statewide.
Through this collaboration, we've given hospitals tools to do root cause analysis. And for central line infections, catheter-associated infections, we've seen significant, by significant, 20, 30, 40% drops in rates over a very short period of time.
It's a matter of how do we take the really great programs and processes that have already demonstrated their success and bring those to scale and spread them in all settings. And that's powerful and that's different.
We eventually hope to be able to share best practice and create a learning network so that the participants who have signed up and are attempting to improve, that they can share their learning experiences, and therefore we can then move the dial by improving care and bending the cost curve.
We're going to move from that provider-centered, volume-driven environment to a patient-centered, value-driven environment. What I mean is that value is quality divided by cost, and as we start to really improve safety, quality will improve, cost will drop, value will go up, and as a byproduct, it'll be more patient-centered.
You want to make your care safer. Why not take advantage of this important opportunity to really link with others who have the same goal and who have different perspectives, different tools or strategies at their back, and who are ready to move with you to improving safety.
I believe that the people that run hospitals or run nursing homes are in that business because they want to help people. People pride themselves on that. And I think that the Partnership for Patients and the goals that have been set out are goals that these organizations will embrace and will support.
If you want a system, you set an aim. Aims create systems, and that's what's different.
So this is like when John F. Kennedy said, we're going to put a man on the moon. That created system. That caused NASA to organize a moonshot.
And the same thing's going to happen here, except now we're going to eliminate patient harm in America's hospitals all across the country.
So many of us, out at the front line that are trying to help communicate this program out to folks in the front line find that they're overwhelmed. I mean, I think that Mike Henderson, you and I are working out in the field helping people understand, even though the message is really clear, how we get down to the granular sort of piece. And the partnership it's got great aims, it's based on great evidence, and the fun thing for us is that and Dave Klassen is a wonderful contributor, and Jim Bajan to the Safe Practices for Better Healthcare. Arjun and the infections, we've worked for the last 3 or 4 years to tie that evidence to the papers. But the challenge is those barriers, those chains of habit are too light to be felt until they're too heavy to break. Those chains of habit are tough. David, as we look at this, if we said 5 years ago, wouldn't it be awesome if there was a government program that targeted the stuff we know works, And there is now, but 5 years ago or, 6 years ago, there wasn't. Now where are we out at the front line? Because you're out there helping hospitals, giving consultative support to do just these things that are described by the program. Give us a reality check so that this could be a learning moment for all of us.
Yeah, I have a mother who's 85. She has congestive heart failure, and she has atrial fibrillation, and she's on Coumadin. And she goes in and out of the hospital. And unfortunately, even in today's world, virtually reliably 100% of the time, her medication gets screwed up when she leaves the hospital. So we still, I think...
And you're one of the top guys in the world in medication management, and your mom.
It still happens.
Still happens.
It still happens. So I think the point here, and the reason this program is so important is, despite all of our focus on safety since 1999 and the IOM report to Air is Human, we still have a long way to go. And clearly where those vulnerabilities are, transitions in care, I think, which we all recognize and are a major part of this program, and I think deliberately so. So I think that's sort of the test for me. When my mom can go in and out of the hospital, get her medications handled correctly, I'll feel much safer about the system. But still today, I think it's a challenge.
We need a system, big barriers, the beginning of the beginning. Bill, I love the way Bill helps put into perspective. Pilots, we talked about aviation a lot today. We talk about the term helmet fire. Helmet fire is when the oxygen inside of like a pilot's helmet in the military catches on fire, and it's really painful before you die. And so most of our caregivers out there are in a helmet fire over measures. There are so many measures. I mean, even 5 years ago, it was 1,000 measures in 1,000 days. How can you guys bring us these NQF safe practices? Bill, you do a great job of helping us understand how to go from national reporting, regional reporting, local reporting, and then over here with performance improvement measures. Can you give us the context of where we are today? You and David worked on the common formats of data, a lot of wonderful work people don't even know about. Give us a perspective. Where are we today on measures? Because one of the, docs will watch this video and then go, yeah, but they haven't fixed the measures. And they really have, and they're getting fixed, and they're not perfect yet, but give us where are we?
Well, we're making progress. I think that's the place to start. One of the things, sometimes when people talk about measurement, they say, well, measurement isn't everything, because you can measure things and then nothing happens. And that's true. Measurement isn't enough. But why measurement is important is that in quality and safety, you can't tell if you've made any progress if you don't measure. So measurement is absolutely integral so that you can say, here's where we are today, and here's where we were yesterday, and we've made some progress. Everybody is mentioning central line infections because we've made a lot of progress there. But why do we know that? We know that because CDC has a measurement system, and others have adapted measurement systems so we can track where we go. The problem has been that everybody's measuring things the wrong way. Everybody has a different measurement system. And IT is very exciting in the fact that it makes measurement, more powerful measurement, possible. But everybody also builds their system and they write code, and then they have an investment in doing it the way they do it. So we can't all learn together. There isn't collective learning. So we need to count apples to apples together. And so that basically, all of the different measurement systems that are out there today helps the individual people where they are, but we don't learn very fast either about the care we're giving or how to make the measures better themselves. So our agency has been actually working in conjunction with CDC and FDA and the other federal systems to develop a uniform set of measures. We also work with the private sector, I might add, and we get public comment, and we've developed a common set of measures, starting with patient safety in hospitals and then expanding to nursing homes, which are called the common format, and Farzad referred to those before, the common formats, where it's a unified way of measuring things that is scientifically supportable and can get better over time. And once everybody begins measuring certain simple things like central line infections, which they're now doing, and we see the progress there, but falls, pressure ulcers, all the medication errors and all those other things that are plagues on patient error in hospitals, then we can begin to make much more rapid advances.
There's a lot of inertia because of just ignorance that there is progress, and I think that's where all of us in this room could really be message bearers, that collaborating and joining the partnership gives you the opportunity to see where the measures and to have is that a fair statement, that being involved in these collaboratives is not only good to help you do better, but to understand how to measure doing better? And I know Farzad, you were going to say something, but I wanted to go to Arjun first. He flew in from Atlanta just specifically for this panel, and we're so grateful. And we're so grateful for your leadership and participation in our Greenlight program in the infections area. We've talked a lot about the measurement of infections, and we've had you speak on our national webinars as well. From what you're hearing today, what's the best message you can give us that we could put to action? Where are we today on these infections that we could really act, since you came in specifically for this
Absolutely, and I was thrilled to be able to join you for this, Chuck, and appreciate the invitation. I think what Bill said is key, that measurement is so critical to improving performance. It's not an end in and of itself, but measurement is an absolutely critical means to the end that we're trying to achieve, which is the elimination of these infections. We've made huge progress. I think that we have seen a real transformation in how we view the measurement of these infections. We are seeing an increasing number of these infections now be publicly reported, with states initially leading the way, requiring that hospitals report information on some of these infections to the public. The federal government has followed suit, and an increasing number of these infections now have to be reported nationally. And there's no question that this awareness of the problem, the transparency, the culture of transparency that's created when you publicly report and you say, this is how we're doing. We may not be where we want to be, but we're going to show you where we are, and we're going to tell you, as our patient advocates has told us, tell us what you're doing to get to where we want to be. It's okay if you're not there yet, but tell us how we're going to get there. And what we're seeing is people increasingly using measurement, and I think the point that people are making is so vital. The measurement that we want is data for action. So what we want are not measures that at the end of a year tell us, well, how did we do this year? We want measures that as we're moving forward, that we can tell us, the facilities can look at their own information month to month, week to week, and say, well, how are we doing? What are we going to do better? And that's one of the reasons why we're excited that the measurement system that we use to measure these infections that Bill has mentioned, the National Healthcare Safety Network, is that type of system that allows local data for local action. Facilities have access to the data. They know how they're doing, and they can share that information with us so that nationally we have a sense too, but it's the same system. And that's exactly what you measure. We don't need 2, 3, 4, 5 different systems to measure the same thing. You want one system that has multiple purposes.
Fantastic. Farzad, you had a...
Yeah, I was going to say, we measure both to monitor progress, but also to signal what's important. And what you're seeing from the federal government on this panel, and I think more broadly from the Department of Health and Human Services, is something that's unusual for government, which is focus. It's focus. It's saying, let's focus on a few key things, and let's get all hands on deck to solve those. And quality measurement, the problem isn't that we don't have enough measures, right? We, as you say, providers are saying, oh, there's 1,000 measures. What do I focus on, right? And what we've done is to say, let's focus on a few key things: patient safety, Million Hearts program around cardiovascular deaths. Let's focus on a few things part of the National Heart. And then look at, do we have the right measure for that? David mentioned his mom has AFib and is on Coumadin, right? Half the people on Coumadin in this country are on it because of AFib. Do we have a measure that is nationally endorsed that looks at safety of Coumadin? Whether all people who are on Coumadin, whether their INR is therapeutic. Not too high, not too low. Do we have a nationally endorsed measure for that? No. We took our eye off the ball, and we're making great progress on getting to those measures that matter, that focus on what really is at hand.
And the disappointing thing, my mom's on Coumadin, and we wrote a meta paper on that and found that routine care even by pharmacists far exceeded what systematic care by pharmacists exceeded what doctors were doing in their office, because they were giving homeopathic doses of Coumadin, and it's crazy.
And without having a measure, you'd never know.
We really need to focus. I want to make sure that we cover everybody, because we got the partnership in, and I just want to make sure everybody's covered. The QIOs are a terrific resource for tying into the partnership. And many organizations, even in this room, didn't know what the QIOs were, even safety net hospitals that could tap into them who desperately need help. And I just wanted to give you a chance to make the pitch for what they do, again, because we have a different audience that logs on at different hours, on what the QIOs could do. And then come back to you, Paul.
Thanks. So I think one of the important things is that we use the measures that my colleagues here are referencing. We use them in a number of ways so that the QIOs, which exist all throughout the country, every state and 3 of the territories, they exist in those areas, and we consider them the infrastructure that's out there to help us carry out these national goals at the local level, where care really occurs. They provide support to hospitals, nursing homes, home health agencies. Most of the providers can tap into the resources of the quality improvement organizations and learn how, working in the communities that they serve, to utilize measures to monitor improvement, to implement some of the great evidence-based materials that are becoming more and more available, and then monitoring how their improvement goes. One other thing I want to mention, because I happen to come from an agency that does payment, is that, which is the Center for Medicare and Medicaid Services, is that we're also using these measures to make sure that we're aligning payment with the kinds of outcomes that we would like to see. So often in the past, we've just paid and paid for the services and the volume, but no more. We want to make sure that we are aligning payment with better outcomes, and that's happening at this very moment that we speak.
So if we have safety net hospitals or rural, I know Dr. Williams is here, and congratulate you all for being in the top 100 hospitals in America, a small rural hospital. But there are many that are not as wonderfully led as yours is, and are really, really struggling right now. Can rural hospitals and safety net hospitals contact the QIO for help? Because I know even in this room there are some that are representing them. Is that something they could do to get help and maybe want to participate with these?
Yes, not only we would love for them to contact us to get help, but also to share the things that they're doing, which could serve as best practices for others. So it's a give and a take. So we learn, yes. So we encourage you to contact your quality improvement organizations. Partnerships for Patients, Million Hearts, and many other projects are a part of the work that they do.
Bill, PSOs. So we've got great PSO. We've got lots of PSOs, patient safety organizations that protect information that would allow us to really cross-collaborate. There are great ones like ISMP that are just doing terrific work and have always have, even before they were a PSO, in helping us understand medication errors and harm. And Mike Cohen was on our panel or our committee on the National Quality Forum State Practices and that. Can you give us kind of the latest on how, it's almost like Disneyland. I think David Hunt and I talked about it. All of these federal programs, you're not sure what is a ride or what's under the ground that's the tunnel between the rides at Disneyland. There are so many of these things, it's hard to understand how all the structures fit together. Where are we with the PSOs, and how could we take advantage of our PSOs or that framework and tie back to the common frameworks?
Well, just for numbers' sake, right now there are 77 PSOs in 31 states in the District of Columbia. Many people may say, what's a PSO? I guess the easiest way to explain them is that professionals have been reluctant to do peer review if they thought they would be sued the next day for their deliberations about the mistakes that they've made themselves. So many states have passed peer review laws to protect professionals when they deliberate on behalf of the public welfare. And those protections, by and large, don't exist outside hospital walls or beyond state boundaries. So a hospital chain, for instance, wouldn't aggregate information necessarily and analyze it because that information would be unprotected. What the Patient Safety Act did, which created PSOs, was to essentially set up uniform standards across the country to protect peer review. And so patient safety organizations, which are voluntary, nobody has to be one, but patient safety organizations get together and they provide these uniform protections, and then any licensed provider in any of the states in the country can get together and deliberate about quality. What it's supposed to do is to encourage increased level reporting and increased analysis about how to make care safer and a better quality. The program is off to a fairly rapid start. It's only a couple of years old, a few years old, and as I say, we have 77 of them across the country. They're just beginning to collect information. Obviously, we can't add, if somebody counts things one way and somebody counts them another way, we can't add that information up. So they are using common formats, and we're about to begin this year to get the first information aggregated nationally, where we'll begin to learn. So patient safety organizations should be a stimulus for more review, more honest reporting about what's right and what's wrong with the delivery of healthcare in this country.
Fantastic.
More analysis and more learning.
So I want to go to Jim.
At the local level.
To Jim Bajan, and then back to you all regarding the partnership, since that's where we started. Jim, you led the Patient Safety Center at the VA and had both the benefits and probably different barriers we wouldn't know about, but you did have the opportunity to really take a very standardized approach. You were a great leader of that. It showed great results. Now you're out with the rest of us, and you're in an academic environment, and you have all of the chains of habit that I described earlier and that kind of thing. Now that you can see back through a different lens at programs like this, what advice do you have to those of us out at the front line to take advantage of these programs? What's the best practice to take advantage of these great programs now that you can look back, but you've done it the other way when you had a little more control, but maybe other barriers?
Well, yeah, I think there's some differences, but there's many similarities. I think one, as was said before, you need to have a crisp goal. Why are you doing it? Yep. And that has to go down to the people you want to get reports from. If people are reporting whatever it is, whether it's outcome data, whether it's process data, if they think they're just doing it because you told them to do it, you're going to get inconsistent, inaccurate results. I think you have to also show that it's a benefit to them in some ways. And that means most people, as was said earlier, want to see the patient do better. They want to see, and that's why they're in healthcare. So if they report something that's about outcomes, they understand how that outcome report will add to us controlling the system better, understanding it better, having better interventions, being more proactive. If it's in the case of process, the same way. Another thing that hasn't been talked about, or maybe directly, is that there's also reporting to identify vulnerabilities. These aren't measures of incidence or prevalence. If you look at those type of, I'll call it surveillance, and Arjun will permit me, it's not surveillance in the same rigorous way that CDC might do it. But I don't need to have a statistically significant sample if I'm looking at devices, for example. If there's a device that I find this device has a programming issue, a performance issue, if I see that it's a property of this device, I mean this class of device, not just this individual one in my hand, I don't need 15 other reports. One suffices, and then I can go forward, as David was saying, to investigate, understanding what's behind it, and then what we do. So I think there has to be feedback. When you get a report, there has to be feedback to the reporters to understand why it's worthwhile, whether it's we took action, it's demonstrated improved patient care, or we've eliminated vulnerabilities or hazards. That needs to be done. So I think there's, for quality control, like run chart type stuff to say, are we where we want to be? There's outcomes. Did we get to an outcome? But then there's also surveillance or to identify vulnerabilities, and they're different. And they need to be different.
And what you just said is a mouthful. It's sophisticated. It's going to require boards. So those of us that are representing trustees, if we get after the election and go into massive cuts in Medicare, it's going to be very tempting to cut your quality and safety program. What do we always do? We cut housekeeping, nursing, safety, and education. And
yeah, well, and could I interject on that?
Yeah.
You know, I think a really important point, if there were cuts and you had to make the choice, and I don't think I'd want to make them, which one would I want to have first? I probably would say I would always want to have the reporting that gives me where the vulnerabilities are. Because if you make the vulnerabilities well known, there are plenty of people who will, you know, even if we can't orchestrate them as we optimally like to do it, they will say, oh, here's a problem, I'll fix it. You know, you can't fix problems you don't know exist. If we strictly look at outcomes without any of the others, that doesn't give us the ability to look beyond this focus problem to others. If you're identifying vulnerabilities, there are a host of vulnerabilities that different people will look at solving. You know, there's medication problems, there's HIT problems, there's a whole host of things. So, I mean, you would never want to make that choice, but I think the vulnerability one is more nebulous, but I think it's the one that allows people to really identify the problem.
Act right away. Absolutely. So coming back, just for time, I want to come to these guys, and then we'll come back to everybody. But one of the things that I see out where I live on the West Coast is hospitals are in collaborative fatigue. Everyone is having a hard time recruiting hospitals to submit data because they're just overwhelmed. I mean, they just don't have any more staff to report one more thing, and it's like they just get into the helmet fire that I described because we're doing our imaging collaborative effort, which can deliver immediate results. I mean, our overuse of CT is 20 to 30%. You know, our inappropriateness of imaging orders are 40 to 60%. I could show you Mike at his hospital in 2 weeks after a 45-minute briefing on the 5 rights, cut 17 scans, and 2 of them were kids. That was ionizing radiation. I'm a radiation oncologist. That's carcinogenic. That's pretty cool at a small rural hospital. So we could give them immediate feedback on things, but when we talk broadly, they're so overwhelmed by all of these collaboratives. Give us some advice on how we can get trustees to put dollars on these collaboratives and how we can hit this collaborative fatigue issue, because I'm sure you're running into it. And I know in California, as I talk to them about, hey, are you with the partnership? You know, and I'm cheerleading for your program, guys. And they're going, oh my gosh, you know, one more collaborative, I'm going to, you know, blow my head off. And that's what they say off the record. How can we, are you all experiencing that? Are we experiencing collaborative fatigue? Everybody's wanting to collect data. So help us with that to help you, because that's a barrier that I'm having trying to help get folks in your program. They can join, sign up, but are they really going to be actively submitting data? And how do I make the case to the trustees to say, put some more bucks on this horse?
Great. Thank you, Chuck. Yeah, I think what I'd like to do, kind of in responding to your question on this, is circle back to what Farzad said earlier, because I think it's the heart of the matter, that the Department of Health and Human Services and the Partnership for Patients has done something, I think, extraordinary that we've never done before. We've said focus like a laser on these 2 aims, a 40% reduction in preventable hospital-acquired conditions by the end of 2013 and a 20% reduction in 30-day readmissions. We've never done anything like that before. We usually have, you know, big volumes of reports with all sorts of aims. This is a different day. And those 2 powerful aims, I think, create an extraordinary strategic asset for the department, but most importantly for the patients we serve and the frontline providers. Because what those aims say is whatever it is that you've got coming your way, whatever collaborative it is, whatever agency of the state or a nonprofit sector or the federal government is coming to you with this, focus your efforts around these 2 aims. Align your programs, your platforms, your assets, whatever they are, with these aims. And together nationally, it creates the opportunity for us, I think the first time, to begin to perform as a system. Aims create system, and that is a huge asset. And I think that's really at the heart of cutting through collaborative fatigue, as you describe it. Zero in on these things that matter. We didn't choose those things by accident. Secretary Sebelius and Don Berwick have said and have focused us on getting better care, better health, and lower costs simultaneously. And if you want to get better care, better health, and lower costs, focus on these aims because they're the low-hanging fruit for doing that. We know how to do this. Organizations all across the country, many of which were profiled on the movie earlier today, like Ascension Health, have shown us that this is possible. So the problem isn't whether it's possible. The problem is spreading it throughout the entire nation. And I think that's the opportunity that this partnership creates. I want to say one more thing, and I'm sure my co-director, Dr. McGann, would like to jump in here. But the one other thing I would say is that I'm a 26-year veteran of federal service. So I've worked in the federal government for 26 years. I never dreamt when I joined this organization that would be the case. But it's been extremely rewarding. And something has happened that has never happened in my career. We have a departmental team. Farzad's staff, Arjun's on it, Jean Moody Williams and her staff are on it, Bill Mounier and his staff, Noel Eldridge, Paul Moore, a lot of the people in this room, Dr. McGann and myself, and 30 others. And we get together 3 times a week, and we are coordinating for real the activities and the platforms of the Department of Health and Human Services to bring about national change on these aims. That's never happened in my experience. We've had task forces, we've had things. This is different. You know, it's a very different thing.
And the thing that I want to remind ourselves is that they also listened, because it was in October of 2010 when you were here as a visitor, because you weren't in the program, and we had 30 CEOs from around the country, and we had Mike Henderson and his chief of medical staff, and we had Steve Swenson and a lot of people in this room, and they listened because they just didn't decide on these aims out of the blue. They asked Mike, and they asked a number of these organizations, and Mike Murphy from San Diego, the Baldrige winner, and said 40%, it was exactly what you guys are targeting. They asked our CEOs from our test bed, and you know what they said? Yes. So although we have the fatigue, we have CEOs that say yes. And I think that's what we have to keep affirming for you, even though, and I don't want to throw you the barrier of they've got the helmet fire so they won't do it. But we have the C-suite that said yes, and they listened. You know, the government listened, and they became exactly what was proposed in a closed-door session when, Bill, you spoke in October 10th in here at the Press Club where we had the meeting down the hall. So it's exciting to see the aims, and it's exciting to see the focus. We would want you all to understand, though, the helmet fire is going on, and the fatigue is really big. When I go to Paul, because he was going to say something, and then Arjun. Paul.
Thanks, Chuck. You know, there are 2 things necessary for a successful project at any level, in government or industry, anywhere else: will and execution. And what we're seeing is not the helmet fire and not the fatigue. We'd encourage anyone who's feeling that to listen to what we're saying. You just said it yourself. Farzad said it. Will is associated with focus and with the desire for execution. We have 4,000 hospitals actively participating in our 26 hospital engagement networks. We've got hundreds and hundreds and hundreds of run charts of results coming in, and we've got a building momentum and a desire to do this right. And Sully Sullenberger said it this morning when he was talking about it. They asked him, well, how did you do this? How did you do this remarkable thing? Was it 208 seconds? He said, I focused on what was important.
Yep.
And I let the other stuff go behind. And it's hard to do that in an emergency. And it's also hard to do it in big government programs.
I think you're picking up on that in the movie as well. We asked him the 3 things. He imposed a calm when he was in terror. Well, yes. They're kind of in terror right now. Yeah. And the second thing that he did was he put a structure on chaos. You're doing that and helping us with that. And then it was prioritization.
And there's a great calm, Chuck, that comes from coming together as this partnership is with its alignment. So the people that are feeling that, and healthcare is in a creative destructive phase right now. And the way to deal with that is to come together and talk about it and work toward common aims. That is the answer to this fatigue that you're talking. And so what we say to people that are feeling the fatigue is come forward and talk to some of the leaders in our network, the Ascension Health, the Intermountain Health, even the Joint Commission.
See, that is very helpful, I think, to the fatigue. I would almost said alarm fatigue, so I'm so used to talking about it in ICUs, but the collaborative fatigue. Arjun.
Well, I think building on that point, you know, one of the other things we've seen that's incredibly important with this issue of collaborative fatigue, and we have seen that clearly, and I think we see it a lot in healthcare-associated infections because we've been doing this for a little longer with a lot of these collaboratives. And one of the things that's critically important is also communication. It's bringing folks together so that everybody knows the collaboratives that are going on. When we began working, you know, the implementation arm for a lot of what we do is through the state health departments. And what we told the states is don't go off in a direction by yourself. bring everybody together. And so what the states did is they formed these multidisciplinary advisory committees. So they brought in the CEOs of the healthcare networks, they brought in the QIOs, they brought in the other agencies, the insurers, and they talked as a group, and they said, what are our priorities? What do we need to focus on? Let's all be aware of all the things that we're doing so that I don't start a collaborative in my hospital, and then you start one, and then you start one. Let's all start them together, and let's take what's going on now, let's build on those successes. And that kind of communication, that coordination that we're seeing increasingly at the state level and now with the Partnership for Patients, where a lot of that focus, the hospital engagement networks are working with health departments. So I think that level of communication will also enhance, building on collaboratives rather than creating additional work.
We have to get back on time, so we'll have to stop. But the one thing that I was going to say is that we would be remiss if we didn't thank Don Berwick for pulling us all together in the mid-'90s, because I can trace back almost every one of these safety initiatives, David, to when we were sitting around tables having wine and eating dinner, and when it wasn't cool to be in safety and quality, and it was Don's courage to pull everybody together. And I can still track back so much of all of this to 8 or 10 people that would be getting together, and you're one of those unsung heroes, David. So we're going to thank you, and we'll move to the next one.